Hello, my name is Ravi Vij. I'm from My Cancer Haven. And today I have with me Dr. Nitya Nathwani, Associate Professor in the Division of Myeloma, Department of Hematology and Hematopoietic Stem Cell Transplantation at one of the premier institutions in the country, City of Hope. And we are going to talk about multiple myeloma and how he chooses between CAR-Ts and bispecifics. So welcome, Nitya.
Thank you. It's a pleasure to be here.
So Nitya, first of all, to set the stage, for those that are not as familiar with these different modalities of treatment, what's the difference between antibody, a bispecific, an antibody drug conjugate, a CAR-T, and then we can launch into what we have available commercially and how you use them.
Yeah, sounds good. I agree. So let me provide an overview of the different classes of immunotherapies because the terms can sometimes be confusing to patients. So among the different therapies, we think about conventional monoclonal antibodies in myeloma like daratumumab or isatuximab, which targets CD38, and elotuzumab, which targets SLAMF7. There are also, antibody drug conjugates, bispecific antibodies, and CAR T cells. So at some level, all of these depend on antibodies. So let me briefly explain what an antibody is. All mammals have the ability to create proteins called antibodies that can recognize particular biologic proteins. Our immune system can make antibodies against infections, and in the lab, we can now make antibodies for therapeutic purposes against any protein that we want. Fortunately, there are several proteins on the surface of myeloma cells that are not expressed by many other cells in the body or are expressed at low levels by other cells in the body. So we can use those molecules on the surface of myeloma cells as targets for antibody-based therapies. And in doing so, we use the immune system against those targets, hopefully sparing normal cells in the body. Now, there are many different agents that have been approved or in development with specific targets on the myeloma cells that these agents are directed against. In the case of daratumumab and isatuximab, it is CD38. And then there's a whole host of therapies that are directed against this molecule called BCMA, which stands for B cell maturation antigen. Um, and this is a cell surface receptor molecule that's restricted in its expression to plasma cells with higher expression on myeloma cells. It plays a role in B cell maturation and differentiation, and it's expressed in late stage B cells. It's not expressed in other tissues. So if we think about how a regular conventional monoclonal antibody works, it basically recognizes a target on the multiple myeloma cell, and then the back end of the molecule of the antibody serves as a kind of like a beacon for other cells in the immune system and recruits cells like natural killer cells and macrophages to kill the myeloma cells. And these cells are part of our innate immune system. And these immune cells have the ability to come in and recognize that the antibody is bound to the myeloma cell. And then they kill that myeloma cell just like it was a foreign substance like a virus or a bacteria. And these conventional monoclonal antibodies have been around for close to 10 years in myeloma now. Um, so those were the conventional monoclonal antibodies, and then bispecific antibodies are another variation on this theme. Bispecific antibodies have two targets, and that's why they're called bispecifics. One half of the antibody recognizes the target on the myeloma cell, and the other half of the antibody usually recognizes a molecule called CD3, which is a receptor on the surface of the T cells that activates the T cells. So this antibody grabs a T cell with one arm and grabs the myeloma cell with the other arm, pulls them together, and activates the T cell in the process so that the T cell, which is another part of the immune system, can kill the multiple myeloma cell. And this effect of a T cell killing a myeloma cell with a bispecific antibody is a little stronger than the effect you get with a natural killer cell or a macrophage being activated by a conventional monoclonal antibody against the myeloma cell. So, with these immunotherapies that engage the T cells, the anti myeloma effect tends to be stronger. Now take that one step further and we have CAR T cells. Now this is a technique where instead of bringing the T cell and the myeloma cells in the body through this bridge of a bispecific antibody, we take the T cells out of the body and genetically engineer them to put an antibody that can recognize the myeloma cell on the surface of the T cell. And in that process of genetic engineering, we activate the T cells in the lab, grow them to large numbers, and then reinfuse them back into the patient's body. And here we're infusing a living therapy. So the CAR T cells that are now armed with this antibody on the surface can find and recognize a myeloma cell. And these cells can actually divide in the body and reproduce and create more of themselves. And so this is a living therapy that can live for a long time in the body and provide, hopefully long-term immune surveillance against the myeloma, but at the very least provide an initial wave of anti-myeloma immune activity where these T cells are recognizing the myeloma cell through that antibody expressed on the surface.
So, what are the drugs that we have? We mentioned the CD38s, we mentioned BCMA as a target. So, what are the drugs that we have in the bispecific and CAR T realm today, and what are their targets?
Yep. So, the fortunately we have several different um, drugs that are approved. We have two CAR T cells that are approved. There's idacaptogene viclucel or ide-cel, which was approved in March of 2021. That was the first BCMA targeted therapy to be approved. And then siltacaptogene autoleucel or cilta-cel was approved about a year later in February 2022, also targeting BCMA. Then there was approval of teclistamab in October 2022, which is a bispecific targeting BCMA. And then there was elranatamab, which is another bispecific targeting BCMA in August of 2023. And there was talquetamab, which is also a bispecific targeting a different receptor called GPRC5D, and that was approved the same month as elranatamab in August 2023.
So
So
obviously we have a number of these compounds, and it's an abundance of riches in some ways. So how do you decide in a patient which one of these to use and in what order?
yeah, so I guess the first question is, is this patient eligible for immunotherapy? So if the patient is eligible for immunotherapy, which is typically after 4 lines of therapy, which is the FDA approved labeling at this time. And then the next question becomes, is it going to be CAR T cells or bispecifics? And what factors are going to determine this choice? So, typically we'll start with, targeting BCMA because we have the most mature data for that, and it's a very effective target. So generally, if I have a CAR T cell available, that's what I generally pursue. And that's for several reasons. So, most patients really like the opportunity to have a treatment-free period, and this is possible with CAR T cells. So among the CAR T cells that are approved, my preference is generally to use the cilta-cel product, as that is extremely active and it has, an updated data, a progression-free survival, which basically means good cancer control for approximately 3 years. So that means on average, no additional treatment is needed for, roughly 3 years for most patients, which is really tremendous. And if I use a CAR T cell first, I can still use a bispecific in the future. So we've seen that, when a patient's myeloma progresses after a CAR T, it may still be sensitive to a bispecific, particularly if it's been more than a year since they got their CAR T. Whereas, patients whose disease is progressing on a bispecific are less likely to get significant long-term benefit out of a CAR. And fortunately, since August of 2023, we also have this option of using talquetamab, which has a different target from BCMA. So, that's something that, we'll often go to. And in that particular trial, there was an arm that included patients who had previously received T cell redirection therapy, and the response rate to talquetamab, even in those patients, was very high. So that's another good option. And finally, the other reason to pursue CAR T cells first is during that treatment-free period following the CAR T cell infusion, their low blood counts would have resolved, and their T cells would also hopefully have recovered. So T cell redirecting therapy would still make sense. And some of the other options to consider would be disease burden and access as well. So if my patients have a large disease burden and they're rapidly progressing, I know I may not be able to safely get them through the CAR T cell process, which takes more time. If I don't have a good bridging option, then the bispecific may make more sense. So generally, we stop myeloma treatment about 2 weeks before collecting the T cells in preparation for the manufacturing process. So we want to know that, in those 2 weeks, will the myeloma remain manageable or is it going to explode? Another factor, of course, is patient preference and what potential side effects they may be able and willing to tolerate. CAR T is a more intense treatment, and for a frail patient, for example, with a large disease burden, a bispecific may be a safer choice. And then, regarding access, if they're coming from a long distance and they have adequate caregiver support, then a one and done approach, as is done with CAR T cells, may be preferred. Many community practices are not giving bispecifics yet. So if patients live very far from our center, for example, they may prefer CAR T cells. And I think, the bottom line is that if I will not have a CAR T cell available in an appropriate time frame based on the disease burden, or if there are issues with access, then I go to the bispecific. But I'll typically start out with the CAR T for most patients.
So that obviously tells us how you sequence the CAR T and the bispecifics. Thank you for explaining that in detail. What about the GPRC5D targeting bispecific? I sense you said that you generally tend to use the BCMA-directed therapies before GPRC5D-directed therapies. Is that what I took away from your discussion?
Yeah, generally I'll go for BCMA targeting therapies first, ideally with a CAR T cell. If they don't qualify for that for whatever reason, or it's not a safe option, then I'll generally go with the GPRC5D targeting bispecific, which is talquetamab.
So have you in any case sequenced talquetamab before BCMA directing therapy, either as a bridge to a CAR T or as a therapeutic modality before going to a CAR T because there was not slot availability immediately for a BCMA CAR T?
So I have given talquetamab before BCMA targeted therapy, for patients on a clinical trial where we've had a clinical trial with talquetamab that's been open for several years. So um, I've given some patients talquetamab first and then taken them to CAR T when they develop progressive disease on that.
So, as far as the drugs to avoid before a CAR T or a bispecific, are there certain drugs that you try to avoid before exposing a patient to bispecific or before collecting CAR Ts?
Yeah, so I would say, before leukapheresis or the actual CAR T cell collection, we try to avoid, we stop therapy for about 2 weeks, and I generally try to avoid, alkylator therapy. And I, that's the main thing, like very cytotoxic therapy. I try and avoid that, and I give them 2 weeks between finishing the therapy and the collection, which is leukapheresis.
And for those that are progressing beyond the currently available bispecifics and CAR T for BCMA and GPRC5D, is there still options that can be exercised?
There is another option. There's a different target called FCRH5, and there's a drug called civostamab that's in development. We have a clinical trial open at our center, and we've actually used that for a number of patients, and it's also very effective. And one of the benefits of that treatment is that it's given for a finite duration. So we've given treatment for a year and then stopped it. And many patients have actually maintained their response, and we actually have patients 2, 3 years out from after receiving that therapy who still remain in remission.
So it seems like there is hope beyond BCMA and GPRC5D, certainly. And what about CAR Ts to GPRC5D?
Yeah, actually, that's been incredibly exciting. So there was an abstract presented at the ASH meeting a few months ago, where we saw, in a trial, the response rate was close to 90%, meaning almost all patients responded to this CAR T cell targeting GPRC5D. And one of the challenges with GPRC5D treatment is this altered taste sensation called dysgeusia. And we also see some skin and nail changes as well. That's quite significant with talquetamab, but with this GPRC5D targeting CAR T cell, that seemed to be lower. Like the dysgeusia was only seen in about a quarter of the patients, and it was more manageable compared to talquetamab, where it was seen in more than half the patients. And these taste changes can really be quite distressing for patients. Some of our patients have said, everything tastes like cardboard or sawdust, and things that they used to enjoy eating now taste completely different. So that can really be a very bothersome side effect. And this CAR T cell targeting GPRC5D has much less of that.
And before we end, where do you see CAR Ts and bispecifics moving in the future? This is, you told us that right now you're restricted to using these in the fifth line of therapy and beyond. But how do you see the future evolving, and how are you going to use them in the future?
Yeah, so that's I'm not completely sure, where I will end up using them. I think I would like to use them earlier. So I think, currently we're using it in the fifth line, which is too late. I would like to use it, in earlier lines. I probably wouldn't want to use it in the first relapse yet. Probably the second or third relapse is where I see it being used. And the reason for that is, we are seeing some excellent responses even in the fifth relapse in patients. And while the responses are excellent, we're not yet seeing cures. and we are seeing, some rare side effects. We're seeing some delayed neurotoxicity and, some other side effects. So I'm not sure I would want to use it for the first relapse because we still have, many other options which have a much longer where we have a much longer track record. So I'd probably want to use those options and then think about CAR T cells and bispecifics in, you know, second, third relapse and somewhere in that on those lines.
Is there any demographic where you would consider using it in second line, early relapse, high risk cytogenetics, extramedullary disease?
Yes, I think all of that. I think in truly high risk patients, in patients with double hit myeloma, in patients who have functional high risk disease who have relapsed within 2 years, definitely patients with extramedullary disease, and all of those patients, I would be eager to use it earlier. But for a standard risk patient, I would probably not use it, very early.
So obviously, we're in March 2024, and the FDA is expected to rule on at least CAR Ts being possibly used as early as second line in April. And then, what about bispecifics? If 5 years down the road, uh, bispecifics too are available for use in earlier lines, what role do you see them playing? I know it's too early to speculate, perhaps, but just would love to know what your crystal ball says.
So I think, bispecifics can and should be used earlier on. I think the key is going to be, using them, um, for a finite duration and probably spacing them out a little bit more. So, we've already seen some changes coming out where, they don't need to be dosed as frequently, not necessarily every week, because we are seeing a lot of infections with frequent and prolonged use of bispecifics. So I think, once we can make them safer and also, easier, I see them being used in earlier lines.
Well, I really appreciate you taking the time to tell us how you use bispecifics in CAR T and how you intend to use them in the future. This has been very informative, and I hope that I can count on you to return to us for another podcast in the future on another contemporary topic.
Sure, I'll be happy to.
Thank you very much.